request Dr. Gopi to.
Good afternoon. At the outset, I thank probably there is no space to walk. I thank the organizers probably for including the faculties as small speakers. Because we initially thought everybody must be external. There should be internal examiner also. So we thought we include some more faculties also. Small topics, a few topics we are doing. And this is something we want to talk because this has not been included in any trials. That's why I wanted this. Till date, we don't have any guidelines for diabetes in the elderly. For example, you take ADA, all are focused on individual less than 75, 65. So you cannot just blindly apply whatever is available. For a 45-year-old man, you cannot apply to an 80-year-old man. So it is different. Diabetes in the elderly is different. What is different? So let us just see. So these are references. Because I couldn't get guidelines, but a lot of references are there. Because even there is so latest reference I can get 2013 diabetes therapeutics. This is management. This is ADEA. What is ADEA? What is ADEA? Not ADA. So something new. Australian Diabetes Educators Association. Where they form guidelines because then the doctors, sometimes paramedical people form guidelines. Australian Diabetes Educators Association. Of course, Diabetes Care is a nice article. And this is a textbook. This is the only textbook, is the very latest textbook, 2010, the textbook of diabetes. See, this is the drawback. That's why we have to read about, you cannot follow any guidelines. You have to read literatures because due to the exclusion of older people from clinical trials. So many clinical trials, you take any drug, older people, they're just, there's some problems. You cannot compare a 50-year-old man with an 80-year-old man because physiology is different, pathology is different. Then what is elderly? Any idea? What is elderly? Universally, not in India. Universally, what is elderly? What is age group? Above 65. Any other choice? No, I am not talking phenotypic definition. Age is different. Phenotypic, some people look aged at the age of 40. That is different. So this is the elderly. See, young old, old old. Young old means 65 to 75. And old means, that is internal definition. This is internal definitions, okay? So anybody 65 and above is, for the definition today is elderly diabetics. And what is different? What is different? Diabetes in an elderly is different from a non-elderly population. It is different in so many things. It is different in so many things. It is definition, incidence, pathophysiology, presentation, features. So many is different. You cannot blindly apply your knowledge so for gain to an older man. So many things are different. And first of all, let us know what is special about elderly. Why you want to talk on this topic? Because they are special. They are special population. They are senior citizens. They need some consideration because this is the list. One word I want to underline is this is vulnerable to hypoglycemia. They can live with hyperglycemia for several years, but one hypoglycemia will kill them. That is the message today. They can live with hyperglycemia for a few years, but your hypoglycemia would have killed them. So be careful. This is only long to note. Other things are there, as usual. Comorbidities. No old man is free from other problems like osteoarthritis, vision loss, hearing loss, cardiovascular problems, and cognitive dysfunction. This is very important. Cognitive dysfunction. Yesterday we had, so Professor Krishnamurthy was telling how to assess cognitive dysfunction. This is very important. Every diabetic old man assess the cognitive function, which we never do in a young man. We hardly spend time. And our impatient mortality is more, poor follow-up. They are dependent. And this is very important. Their liver and kidney is functioning suboptimally. So you cannot give the maximum therapeutic dose in a given book to an older man. Metformin is 3 grams. But for them maybe maximum 1000 grams. It's not more than that. So what is incidence? Actually, as the age increases, sugar increases, no doubt. But why increases? Why age increases, diabetes increases? What is the mechanism? What is the mechanism? This is another slide to show. As the age increases, obviously whether it is man or woman, incidence increases. What is the cause? Beta cell mass coming down. Okay, good reason. Any other reason? Any other reason? She's correct. You are graying hair. Your vision is coming down. Naturally, beta cell mass is also, beta cell mass and functions are coming down. Not only mass, functions also coming down. Okay, any other cause? Comorbidity is not the reason for diabetes. Yeah, it causes what? Insulin resistance. There are two reasons, very obvious reasons why as the age increases, increasing insulin resistance, decreasing insulin secretion. Very simple answers. But why insulin secretion comes down is age related, you can say. Just like my graying hair, my poor vision, my beta cells losing function. But what is causing insulin resistance more in aging? What is the mechanism? You said one, physical inactivity. They are not as active as their younger counterparts. What another reason? Why more diabetes in the elderly? Because decrease in secretion, increase in resistance. And this is the data. For every decade, your blood sugar goes by 0.38 millimole per decade. So if you do OGT subsequently, naturally blood sugar go down, increases. But why insulin resistance is more in elderly? There are the four reasons. Adiposity. Yeah, old man may be thin, but he's relatively obese. He's relatively obese, metabolically obese. Okay? And he has, this is the most important. You must know this sarcopenia, muscle mass is coming down, which is the most important site for glucose uptake. Insulin action. So sarcopenia, use this word. Elderly means sarcopenia. Elderly means sarcopenia. Okay? So glucose intake is less, often they are physically inactive, and they be taking a lot of drugs, co-drugs. So there are four causes for increasing insulin resistance to make them more diabetic. And the mechanism is it is post-receptor defects, and there is also poor vasodilatation in the muscles. And pathogenesis, it's no way different. It's no way different from the other population. There is usually whatever you can say. Reduce insulin secretion, increase adipose tissue, physical activity, all these you can say. Nothing is different. But clinical presentation, yes. How a old man presents with diabetes? You can tell any answer for this question. It's not a typical piece. Polyuria, polyphagia, polydipsia, very rare elderly people. How many people you see elderly with polyuria, polyphagia? Because if an 80-year-old man says polyuria, I think of prostate problem, then diabetes. Whereas a 40-year-old man thinks, I think first diabetes, then prostate. So the presentation is little atypical because their renal threshold is less. So glycosuria is less. So there's no polyuria. And their taste sensation is also less. Don't take water. So no polyphagia. So polyphagia, polydipsia, polyuria is less in elderly in spite of diabetes. Then what is the presentations? These are the general presentations. You may see an old man coming with high sugar and altered sensorium. Very common presentation, hyperosmolar syndrome. Very common, which is we never heard in young people. A 70-year-old man, blood sugar 400, drowsy, you are diagnosed with hyperosmolar syndrome until proved otherwise. This is a very common presentation. And see the anorexia. We say polyphagia, but anorexia is a sign of diabetes in elderly. What is the mechanism? What is the mechanism? Polyphagia is in younger people. The opposite, anorexia is a sign of diabetes. Autoimmune neuropathy, long-standing diabetes, gastric dysmotility, anorexia. So this was the atypical presentations. And this your word must remember. They present with geriatric syndromes. We say syndromes. They present with pains, all body pains, sudden falls. So what is this geriatric syndrome? So typical, maybe asymptomatic, and they are directed during routine investigations or acute illness. But this geriatric syndrome is a kind of presentation. What are the geriatric syndromes? These are the geriatric syndromes. They come with this. Then you discover diabetes. Okay, so many. Now this is most important. Cognitive impairment, depression, so many things are there. These are called geriatric syndromes. And this is more common. Why it is more common? You don't get DKA. You get more hyperosmolar syndrome in elderly. Why? In spite of diabetes more, somehow hyperosmolar syndrome is more than DKA. Why? Exactly. So there is some amount of, this is not absolute insulin deficiency, it is relative insulin deficiency. This is the three reasons. They got residual insulin secretion, is not zero. And they may not persist thirst. So there is more dehydration. So more sugar. And they got impaired renal function. So causes more sugar and dehydration than acidosis. And how do you investigate? As you investigate in a younger population, nothing different. You do lipid profile, renal profile, take ECG, retinal exam, everything same, but except you have to add this. You have to look for this geriatric syndromes. Whether he has got cognitive function, dysfunction. Yesterday he was telling a lot of tests. Tell the numbers, ask them to recall. Okay, what is the day today? What is the month today? What is the year today? What is the time now? Likely. Please assess every old man for the fresh diabetic or periodically. You must assess this cognitive function because it has got a lot of impact on the. Exactly the word quality of life. Exactly, beautiful word. For a 40-year-old man, it's not quality. I want to prevent complications, microvascular, macrovascular. For a 70-year-old man, I want quality of life. In what way quality of life affected by hyperglycemia? It is not. Your vascular complications must be the last to mention. The old man must live happily. So in what way hyperglycemia interferes with the quality of life? Infection, exactly, infection. Yes, nice. Yes, what are how hyperglycemia affects the quality of life? These are the things. Your acute hyperglycemia will produce glycosuria, polyurias, frequent polyuria, sleep disturbances, urine incontinence, dehydration, dizziness, fall, hyperosmolar syndrome, and of course, infection. These are the reasons I want to treat hyperglycemia in elderly, not for to prevent retinopathy. Would already have retinopathy, but he may not develop retinopathy because he may live only for 1 or 2 years, we don't know. The last should be the prevention of complications. So the aim of treatment, so it's again different from elderly. It is for a younger man, it is very different. I don't quality of life, because already quality of life is good for him. Prevent complications. Okay. And diabetic complications in the elderly. If I ask complications in the elderly, you cannot say retinopathy, nephropathy, retinopathy. These are all for the younger population. They present differently. What are complications you come across which you don't see normally in the younger people? One word is common. This they occur in higher rates. There are some unique syndromes. You see only elderly diabetics, not in the younger diabetics. What are the complications? What do you see in elderly diabetics more than the younger population? Any other complications you see? For example, hyperosmolar syndrome. You see even 500 blood sugar in a young man, you did never get hyperosmolar syndrome. He just walks happily. A little polyuria is there. But this 500 in an old man will produce hyperosmolar syndrome. Okay, it's one way of present. So there are a lot of, see, these are the, you see more in diabetic neuropathic cachexia. It is seen beyond the age of 50 and 60. Thin man, painful neuropathies, high sugars. Okay, you rarely seen it. And this diabetic amyotrophy, very classic. You read the textbook, elderly complication. It's an elderly complication of diabetes. And all you have to sit up, not able to squat, get up in the toilets. This is a common problem. It's a sign of diabetic amyotrophy. This again, malignant oxide and so many things. Dementia, hypothermia, hyperosmolar, unawareness. Very important. No man young only comes unconscious with blood sugar 40. Only elderly people come. Hypoglycemia, unawareness. So there are a lot of complications also a little different in the elderly. And this is something you must look for every elderly at the time of diagnosis and periodically. These are two important things, organ impairment and depression. And you can assess it by this, what is called this MMC, mini mental state examination. And what is the mechanism of this depression? What is the mechanism of the mental disturbances? This is the hyperglycemia, dyslipidemia, hypertension, hyperinsulinemia, and vascular pathology. These are the problems which cause these mental problems. And what is the impact of these mental problems? There is increased hospitalization, less ability for self-care, poor diabetic control, decreased treatment compliance. So everything is caused by your mental illness. Okay? Okay, come in. This is what we're waiting. So is it different? Management of diabetes in the early, is it different? Is it different? Is it different? It is little different, not very much different. Only the targets are different. Only the targets are different, nothing else. Only the targets are different. So these are the aims, of course, same as, but only thing this point again appear. You read any textbook, cognitive impairment, depression. These words again and again appear in an elderly diabetes. Take care of them. And this is a very Even recently morning saw Dr. Venkatram was showing HbA1c, what is the guidelines? This is more stringent, less stringent. But if you carefully here, there is no old age, there is no elderly age. So the AD even misses. What is HbA1c for elderly population? Somebody is above 65. What is the cutoff? Even AD doesn't. They vaguely say life expectancy, important comorbidities. There's no word. HB. Okay. No, there are no guidelines. So people have literature has given guidelines for elderly population. First of all, for HbA1c, you divide the elderly population into 3 types. It's very important, very nice point. See the divide. First, you see elderly man divide whether he belongs to group A, B, C. What is A? He has got only diabetes. Otherwise, he is perfectly normal. Healthy means only diabetes, self-care. He can take care of himself. There are no comorbidities. Complex or intermediate stage. A little self-care may be difficult. He has got little coexisting illness. For example, he may have hypertension, he may have dyslipidemia. Okay? And C is very poor. You not treat this man except for see, this is C. This is very important. You must recognize this category. My elderly patient belongs to A, B, C. Then fix the HbA1c. And then what is HbA1c? This is the most important slide of my talk. You divide A, B, C, fix the targets. Even BP is different, target is different. You see the HbA1c, even 9 is normal for a bedridden old man. A bedridden old man diabetic, your HbA1c may be 8.5. Never bother about it. Quality of life important. Don't produce one hypoglycemia and kill him, okay? Less than 8, less than 7.5. There's no 7 or 6.5. Less than 7.5, less than 8. And see the even fasting, even 180 normal. 180 normal for a bedridden old man. Don't enforce. See the BP, little high, 150, not just 140. And there is no primary, don't give statin for a 80-year-old man, thinking it is primary prevention. No question of primary prevention in the C group. But secondary prevention, yes. Whereas this age group, primary prevention, you can take it. So, A, B, C is the most important categories you have to divide elderly diabetics. Calories, of course, this is standard as 20-25. They are little inactive, lower side, 20-25 calories. The composition is the same, nothing different. Okay, but see that they take more fluids. Otherwise, they go for dehydration and hyperosmosis syndrome. See that they are maintaining fluid intake and calcium for elderly women. And this is something special nutrition issues. See, elderly have got their own choices. They say produce gas, this food. They got a lot of nutrient choices, so you have to adjust to their taste. So they are swallowing difficulties. There are no dental issues. You can ask them chapati. He says, I don't have teeth. So a lot of problems are there. And they restrict there on their own, restrict eating patterns. So these populations, sometimes you may give some kind of adding nutrition supplements. This is the age group, you can give some nutrition supplements, not for the younger population. Some dietary protein supplements you can give. This is another thing, very important, altered taste perception. I've heard people, they come, elderly women come, their daughter-in-law says, so tell her, she's taking a lot of salt. It is not her intention. Her taste is poor. Lot of salt she needs for the normal taste. We understand. The family takes some salt. That is not enough for the taste for us. So what's called impaired taste perception, especially for saltiness, sweetness, that leads to over salting. They add salt because their taste is impaired. Just like impaired sensation, you need more stimulus. So you have to tell them, so what is the alternative? You can give them what is called potassium salts. It's available in the market, potassium chloride instead of sodium chloride, which is too salty and can give, of course, sugar substitutes. And coming very important, drug therapy. It's not much different, but some guidelines must know. Drug therapy, how to manage. Only thing is, all drugs, insulin can be used in older patients, but some limitations. And assess the comorbidities, very important. And this is the most important. Blood sugar may be 400. Start metformin 240 milligram BD. Whereas I may start 500 milligram BD for a younger man. For an old man, 400 blood sugar, I don't bother. 250 milligram glycomet BD. Something like, okay, start low, go slow. This is the very most important word. Coming to metformin, still the gold standard for elderly people. Some textbook wrongly say it is contraindicated. Some doctors say, sir, is it 75 years, no metformin, 80 years? Absolutely wrong. Age is not a contraindication for metformin. Still the gold standard. Still the gold standard. Why we are afraid? We are thinking that old people may have impaired renal function. So assess the renal function and prescribe. See, this is the most important advantages. Low cost, no hyperglycemia, no weight gain. That's what we want. That's what we want. And see, remember this point. Just because somebody is lean, don't withhold metformin. Even younger people. I have seen some doctors say, his BMI is low, should I give metformin? It's not a contraindication. Metformin should be there in every prescription, unless contraindicated. So in lean, it's as effective in the lean as in the overweight. But somebody is losing weight on metformin, stop. The patient may object. So I'm losing weight. Already I've lost weight because of diabetes. You will make me more. In that case, you must withhold metformin.
Dr. Gopi, 20 minutes over. 20 minutes over.
5 more minutes. I was given only 20 minutes. So this I think was the last drugs only. But the only thing is, it is not now creatine based. No oral drug is now creatine based. All are outdated, all GFR based. So hold this for GFR less than 30 ml. And caution to stop. This is very unimportant. Any acute illness in a old man, stop metformin. Even common cold, stop metformin. Admitted for diarrhea, stop metformin. That is the most important message. Any acute illness in elderly, stop metformin. And sulfonylureas, very good drug for very high sugars and diabetes. But the only thing is, think of this hypoglycemia. But what are the best sulfonylureas for elderly? Best sulfonylureas. Now tell me the names. What short acting? What are the names? What are the sulfonylureas? So three things textbook, latest textbook say, not a glipizide. I had the opinion that glipizide is good, but they say glipizide can produce fatal hypoglycemias. So best sulfonylureas, glycoside, glimepiride, tolbutamide. But should never give is, these two should never give. Never give. Okay? And no sulfonylureas above creatine 3. No sulfonylureas. Okay? And glynates, very good drug. Very good drug for older people. Because even in renal function it is good. Even for renal function it is good. Again, best drugs, alpha inhibitors, no question asked. Only contraindication is creatine more than 2. Very good drugs for elderly population. Okay? And this is, of course, very cautiously used in elderly population because of osteoporosis. Very cautiously have to use. Very good drug, very latest drugs. If you ask me what are best drugs next to metformin, gliptins. Next to metformin, best drugs in elderly is gliptins. They are coming up, except for the cost. Except for the cost. Okay? Because there are a lot of, with this lecture now, there are a lot of pleiotropic effects. I'm not going into detail. So sitagliptin, see there's a paper on sitagliptin in elderly population. Sitagliptin, a lot of studies are coming about gliptins in the elderly. So you can confidently use gliptins in elderly population. Confidently. Only cost is matters. And they are also very good drugs. Unfortunately, the only restrict is cost. Very high cost. Otherwise, very good drugs. Insulin therapy, no question asked. Whenever you feel like giving insulin to an old man, give insulin. There's no still indication. Okay? Only thing is, there should be an indication for insulin. But there are no data for these drugs for elderly population. Blood pressure, this is the range. 140 to 100, but you may go up to 150 also in elderly population. But systolic, diastolic, 70 to 90. I'm not going to detail, this is the, and this is something different, isolated, 160 by 70, 190 by 90, systolic hypertension. The best drugs are, this is the order for, must use for systolic hypertension. Okay, this is the order. Yes, ARB, clothianidone, CCBs, this depins, beta blockers and alpha blockers. What are best ARBs for diabetics? As on today. As on today. Tell me set on and Only these two. Valsartan and telmisartan, the best ARBs for all diabetics. For all diabetics, okay? And this is another word. I want just one more slide. This is the slide. Osteoarthritis is very common in elderly population. By giving one drug for osteoarthritis, takes care of diabetes also. Is that a drug? Diasterin, exactly. Please try this drug for all. This is a very good drug which takes care of osteoarthritis and diabetes. Okay? And the hypoglycemia is dangerous. See, the hypoglycemia presents as hemiplegia. Hypoglycemia, hemiplegia, give dextrose, patient walks home. Okay? So the risk factors, care homes, elderly homes, you must take care of these people also there. And lean elderly, think of LADA. Don't forget this point. Color blindness is an issue in people. They wrote one more slide. This is the poor drug adherence. Very common. Don't scold any old man for not taking drugs. They got their issues. Whereas you can scold a young man, but never scold a old man for not taking drugs. And of course, atrial fibrillation is very common. Diabetics, very common. Please add. Diabetics, older people, atrial fibrillation is very common. What drug to add? Anticoagulants. Please add. But this is the data. You must add. Okay. So conclusion: diabetics internally is little different. It's different in so many issues. So take care of this. I am focusing on this hypoglycemia and geriatric syndromes. So last slide. There was a couple sleeping. The wife had a bad dream. She woke up scared, cried. Her husband comforted her, asked why she cried. She said, I had a dream that a very rich man and a handsome man kidnapped me from you. And the husband said, okay, honey, it's only just dream. That's why I'm crying. It's a dream, that's why I'm crying. I just want to happen it. Thank you. Thank you. Sorry for the few minutes.
I just wanted to share a small experience of insulin with the old man. Because I had a patient who had diabetes uncontrolled, and I started him on insulin. And he was about to go for a cataract surgery. And his sugar never came down. So I called him to the next visit. When he came, I asked him to demonstrate how you are giving insulin, see whether something is wrong. And to my surprise, ஒரு ஆள் அந்த நீடில் இன்சுலின் எதையுமே பார்க்க முடியல. அதனால் கையில் தடவி இந்த நீடில் எங்கே இருக்குதுன்னு அதில் தடவி பார்த்து அதை வந்து பாட்டிலில் குத்தி அதுலேருந்து எடுத்து சரி திஸ் டே he was giving insulin. He was giving, this is the way he was giving insulin. Then the poor guy said, I changed him. I had a pen. I gave him a pen. ரொம்ப ப்ரில்லியண்ட்டாக சரி இது பேனா வச்சுக்கோ நீ பேனாவில் போட்டு சந்தோஷம் பேனாவில் கொடுத்தமிச்சா நான் ஒரு வாரம் ஆகி கொள்ளல என்னடான்னு பார்த்தா பேனாவில் நீடில் வளைஞ்சிருக்கு பேனாவில் அவரால் திருப்பி அந்த நீடில் போட முடியல இல்லை you could not recap it. That was a problem. See, you should know before you prescribe something, just see whether sight is normal, whether the coordination is normal. Insulin, it's not a question of prescribing insulin. It's a question of watching whether they are getting proper insulin or not. That's the major. Second thing is, the whole elderly, what is more rewarding is the control of hypertension is much more rewarding than the control of blood sugars.
I would like to request Dr. Ramesh to give a moment.
I want to share my experience.